Low-value care is care where the potential harm exceeds potential benefit. Today we'll talk about Inova Health System's initiative to reduce low-value care. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hederle, senior writer for the AHA. In this Members in Action podcast, Julia Resnick speaks with several staff members of Inova Health System in Virginia about their initiative to reduce unnecessary preoperative testing.
Hello, I'm Julia Resnick, Senior Program Manager for the Value Initiative at the American Hospital Association. In this Members in Action podcast, we will focus on Inova Health System's effort to eliminate low-value care. In particular, we will discuss their initiative to reduce unnecessary preoperative testing. Joining me to talk about this important work are Dr. Neetha Goyal, Medical Director of Quality and Population Health, Dr. John Moynihan, Chairman of the Department of Surgery, and Dr. Sonali Pakala, System Senior Director for Quality, Clinical Effectiveness, and Outcomes, all from Inova Health System in Virginia. Thank you all for joining me today. Let's jump right in. So I understand that Inova has been on a quest to rid the system of low-value care. Can you talk a little bit about how that work began and what motivated Inova to tackle this issue?
Hi, Julia. In 2015, analysis from one of our benchmarking tools showed Inova Health System had a $50 million excess cost variation compared to 1,200 plus hospitals within the database. That's when our journey started. The health system decided to make this a strategic priority. A formal department was established that focused on clinical effectiveness, and the way we define clinical effectiveness within our health system is focusing on patients, the provision of the highest standards of care based on sound evidence-based practice, given in an environment which is safe, free from unacceptable risk, and operating a constant dynamic of improvement. And for this, we wanted to make sure this would be successful only if outcomes were transparent, accountability is clear, and there was commitment to clinical effectiveness that was shared by all. So that's how we formed this department and started focusing on all those areas which showed that there was a variation, a clinical variation. And since then, we've been working on multiple projects, as I said, that focus on minimizing clinical variation, high volume, low value add services, and I could name a few, like QAM labs, appropriate physical therapy consults, lab interval testing, some of the choosing wisely initiatives that focused on appropriate testing for certain conditions. Projects we focused on were based on the data from our internal benchmarking tools. Until we had access to Virginia State all-payer claims-based data, that includes 9 of largest health insurers in Virginia, and Medicaid fee-for-service, also Medicare fee-for-service. In March of 2018, during one of our annual board retreats, Beth Botts, who's the president and CEO for Virginia Center for Health Innovation, shared Virginia State Summary of Results for calendar year 2016, reporting period, and that identified 2.05 million unnecessary services per year that equated to around $706 million spent on those unnecessary services per year. Now, these services covered only 42 measures. Then we looked at across the state, how would it impact a patient? So across the state of Virginia, 41% of members were exposed to at least one plus low service, and 37% of services measured were low value. Since Inova is in the Northern Virginia area, we looked at those results, and that showed about $140 million spent on about 560,000 unnecessary services per year, with 46% of members exposed to one plus low service and 42% of services measured were low value. And how did we decide what to focus on? Out of the top 5 low value clinical services that were identified, by the waste calculator data that was used by VCHI, diagnostics and imaging for low-risk patients before low-risk surgery topped the list. It was around 450,000, which equated to around $210 million.
So I think our listeners will be really interested in what exactly you did to address this issue, and how has the work evolved as it's progressed?
Sure. The pre-procedural evaluation of patients in our system was burdensome, confusing, and costly. There was a lack of standardization in our processes, and they put us at risk not only to create frustration for our providers and our patients, but even more importantly, to potentially incompletely evaluate a patient undergoing an invasive procedure. Two ends of the spectrum were observed. Either the patient underwent an entire battery of testing and consultations way above and beyond evidence-based practice recommendations, or just the opposite. A test necessary to safely perform a procedure was not obtained, resulting in either a procedural delay or a cancellation. So our healthcare system came to the realization that we had to do things differently in order to provide that world-class, safe care for patients coming to us for their procedures. We organized a system-wide task force. Members of the committee included surgeons, anesthesiologists, nurses, electronic medical record and IT people, pre-surgical services representatives, quality team members, and patient registration team members. Our goal was to create an evidence-based, system-wide standard that provided a template for the complete evaluation of patients undergoing invasive procedures. Our healthcare anesthesia contracted partners come from two large anesthesia groups. We're a 5-hospital system. Identified leaders from each group collaborated to develop the standard template after a literature review and discussion with like healthcare organizations across the country. We included input from primary care providers during the development of this template, and we found that to be essential to better understand the workflow challenges for these practitioners. Once that consensus was reached, communications to surgeons' offices, primary care practices, and all members of both anesthesia groups was critical to our success. We were changing practice patterns in a significant way, and feedback from each of these groups was an important step to adoption of our new standard. The communication process included not only electronic messaging, but live presentations to medical staff leadership. Our chief medical officer at each hospital were involved. And additionally, our physician relations team, during on-site practice visits, shared these templates with the offices they visited. And we continued to do so-called real-time education when a patient is scheduled for their procedure.
So what has the impact been of all of this work, and how has it affected your patients and the health system?
Late in 2018, when we adopted this testing grid, the first and foremost thing that we've observed is that there's been a great deal of positive feedback from our clinical providers, both surgery and anesthesia. The frustration and confusion around appropriate testing have been completely removed from our process. The pre-surgical services staff has observed significantly fewer calls to their centers from patients inquiring about the previous apparent conflicts and testing requests between their primary provider, our anesthesia teams, and our surgeons' offices. Case cancellations remain low, and importantly, first case delays as a result of this conflicting testing have been trending downward in a rapid fashion.
I'm sure that you have all learned a lot in the process of taking on this work. What lessons have you learned while working to reduce low-value care at Inova?
I think the greatest lesson we learned was early engagement of the people involved in the process, and that interprofessional collaboration was a significant component to our success in addressing this opportunity in a timely fashion. Additionally, sharing the results as we progressed along our journey and then changing our processes accordingly based on that feedback has made this a sustainable work.
I'm sure that your work isn't over yet. So what is next for Inova on its quest to reduce low-value care?
So reducing the utilization of low-value care is a priority for Inova. The reason being our patients. Our patients are first and foremost reason of our existence as a healthcare provider.
and we are very committed to provide the highest quality care to our patients and avoid any harm. Additionally, we want to be the stewards of the healthcare spending. As we know, our nation spends more on health than any other country in the world, and this is partly related to the money spent on low-value care, which we know based on research provides no additional benefits and in some instances may cause harm to the patients. Over the years, we have learned to do more due to concern about missing something or desire to fulfill a patient's request, or sometimes fear of malpractice, and also the fee-for-service system that we are currently in rewards us to do more. Now there's a pressing need to contain healthcare costs, and we, being the leading healthcare providers in Northern Virginia, are in a unique position to do this in partnership with our patients. Internally, as Sonali described earlier, and Dr. Moynihan as well, that we have been focused on reducing the use of low-value care for a few years now. One of the initiatives we currently have is hundreds of best practice alerts in our EHR. These alerts are mostly based on choosing wisely recommendations that guide our providers to make smarter choices when they order certain tests or procedures or medicines. And our internal data analysis indicating the improved quality of care and cost savings generated as a result of this initiative to avoid the low-value services has motivated us to perform better. We have generated $1.7 million in savings close to 3 years' time just by not ordering these services, or you can say essentially by following the guidelines. Inova is a member of Leadership Council at Virginia Center for Health Innovation, which you may know a nonprofit public-private partnership to accelerate the adoption of value-driven healthcare in the state of Virginia. And due to our engagement with Virginia Center for Health Innovation, we have been, first of all, exposed to the state level as well as regional data indicative of enormous costs associated with the use of low-value services, but also we have been at the center of the development of initiatives designed to reduce utilization and promote more use of high-value services. Based on the most recent analysis, which is for the year 2017, the cost of all low-value services across the state of Virginia remains at $607 million for 1.54 million low-value services. For Northern Virginia, where we are, the numbers have improved a bit. $136 million spent on providing 540,000 low-value services, but we continue to be the region with the highest percentage of low-value services when compared to other regions in our state. And based on all of this, our internal analysis, our internal initiatives that have been successful, and the need to do better, then opportunity appeared for us to participate in a statewide project to reduce the utilization of 7 provider-driven measures that have resulted in 1 million low-value services costing about $500 million over 1 year. Based on 2016 data, we were very excited to be part of this project. The project is now named Smarter Care Virginia, and it is made possible due to a grant from Arnold Ventures to VCHI. It's a 3-year project with the goal of reducing utilization of 7 provider-driven measures by 25%. 3 of these 7 measures are tied to our work with reducing pre-surgical testing, which we already went through over last year or so. By participating in a Smarter Care Virginia project, we feel like we have the opportunity to enhance our existing capabilities in this area. We will be able to share what we have done so far and learn from others, because this project involves 6 other health systems in Virginia. So we will be collaborating with them to share and learn best practices strategies, and we will be able to actually measure our outcomes. The other 4 measures are related to avoiding routine cardiac testing, reducing eye imaging for patients without eye symptoms, and reducing the utilization of PICC line for patients with chronic kidney disease. Outside of the Smarter Virginia project, we continue to focus on reducing other low-value services. For example, have a focus on reducing avoidable visits to emergency room, and we continue to promote high-value services such as immunizations clinically appropriate routine cancer screenings, and comprehensive diabetes care to promote better quality care for our patients.
It certainly does sound like your efforts to reduce low-value care are having a significant and positive impact at Inova. Thank you, Drs. Goyle, Moynihan, and Pacala, for joining us today and sharing more information about this important program. It is truly an excellent example of how hospitals can implement operational solutions to decrease cost and improve outcomes. For more podcasts and additional tools, resources, and education to help you advance affordable healthcare and promote value in your community, please visit the Value Initiative's website at www.aha.org/thevalueinitiative. This concludes our discussion today. Thank you so much for listening.